Now moving ahead with further charts. Coming to hepatic complications of liver transplantation, hepatic dysfunction common after major surgery. One is prehepatic, that is pigment overload, hemolysis, and blood collections like hematomas and abdominal collections. Intrahepatic early, especially there will be hepatotoxic drugs and anesthesia. Hypoperfusion will lead to hypotension, shock, and sepsis. Benign postoperative cholestasis, transfusion-associated hepatitis. Exacerbation of primary hepatic disease. Post-hepatic will be biliary obstruction, decreased renal clearance of conjugated bilirubin, and renal dysfunction. Hepatic dysfunction unique to liver transplantation is primary graft non-function, vascular compromise, that is portal vein obstruction, hepatic artery thrombosis, anastomotic leak with intra-abdominal bleeding. Bile duct disorder will be stenosis, obstruction or leak, rejection, recurrent primary hepatic disease. Now coming to the non-hepatic complications of liver transplantation, one is cardiovascular instability and cardiovascular arrhythmias, heart failure and cardiomyopathy. Now in case of pulmonary complications, there is pneumonia, pulmonary capillary vascular permeability and fluid overload. Renal dysfunction, obviously there will be renal azotemia, hypoperfusion injury, that is acute tubular necrosis, drug nephrotoxicity, decreased renal blood flow secondary to increased intra-abdominal pressure. Hematologic complications will be anemia secondary to gastrointestinal and or intra-abdominal bleeding, hemolytic anemia or aplastic anemia, and thrombocytopenia. Coming to infections, bacterial, early common infections, post-operative infection, fungal, parasitic, late opportunistic infections. Viral will be usually late infections and recurrent hepatitis. Neuropsychiatric symptoms will be seizure, metabolic encephalopathy, depression, and difficult psychosocial adjustment. Diseases of the donor is infectious and malignant. Malignancy, beta cell lymphomas, that is post-transplantation, lymphoproliferative disorders, de novo neoplasms, particularly squamous cell carcinoma. Coming to contraindications to liver transplantation, one is absolute and one is relative. Absolute will be uncontrolled extrahepatobiliary infection, active untreated sepsis, uncorrectable life-limiting congenital anomalies, active substance or alcohol abuse, advanced cardiopulmonary disease, extrahepatobiliary malignancy, not including non-melanoma malignancy, skin cancer, metastatic malignancy to the liver, cholangiocarcinoma, AIDS, and life-threatening systemic illness. Relative contraindications are age greater than 70, rare extensive hepatobiliary surgery, portal vein thrombosis, renal failure not attributable to liver disease, previous extrahepatic malignancy not including non-melanoma skin cancer, severe obesity, severe malnutrition or wasting, medical non-compromise, HIV seropositivity with failure to control HIV viremia or CD4 count less than 100. Intrahepatic sepsis, severe hypoxemia secondary to right to left intrapulmonary shunts, severe pulmonary hypertension, and uncontrolled psychiatric disorder. Now, indications of liver transplantation in children and in adults. In children, it is biliary atresia, neonatal hepatitis, congenital hepatic fibrosis, Alagille syndrome, Biliar's disease, alpha-1 antitrypsin deficiency, inherited disorders of metabolism like Wilson's disease, tyrosinemia, glycogen storage disease, lysosomal storage disorders, protoporphyria, Crigler-Najjar disease type 1, familial hypercholesteremia, primary hyperoxaluria type 1, and hemophilia. Now coming to indications of liver transplantation in adults, it is primary biliary cirrhosis, secondary biliary cirrhosis, primary sclerosing cholangitis, autoimmune hepatitis, Caroli's disease, cryptogenic cirrhosis, chronic hepatitis with cirrhosis, hepatic vein thrombosis, fulminant hepatitis, alcoholic cirrhosis, chronic viral hepatitis, primary hepatocellular malignancies, hepatic adenomas, non-alcoholic steatohepatitis, and familial amyloid polyneuropathy. Treatment for refractory ascites is large volume paracentesis plus albumin, dietary sodium restriction plus diuretics. If there is reaccumulation of ascites, consider TRIPS, continue large volume paracentesis with albumin, and consider liver transplantation. Liver transplantation is a definitive therapy. TIPS and large volume paracentesis is a bridge until a liver donor is arranged.